Welcome back to the deep dive. Today we are opening up a file that feels a little too personal for me, and I have a feeling it's going to hit home for a massive chunk of our listeners too.
I would think so. It's pretty universal.
It really is. We're looking at something that we generally trivialize. You know, we treat it as an annoyance, bad day, or just an excuse to cancel plans.
Right.
We were talking about headaches.
It is definitely universal.
Yeah.
But the specific document we're digging into today, Chapter 54, headache, migraine, and tension type.
Yeah.
It really, it shattered my perception of what's actually happening.
Mine too.
We tend to think of it as just pain, right? A sensation.
Yeah.
But this source material, it paints a picture of a massive, complex biological storm.
Exactly, a biological storm. I went into this expecting, a list of painkillers, take 2 of these and call me in the morning.
The standard stuff.
Right. Instead, I felt like I was reading a breakdown of a catastrophic electrical grid failure inside the skull. It is so incredibly intricate.
It really is.
So, our mission today is to stop thinking of a headache as just my head hurts and to really understand the machinery behind it. We need to parse out the difference between the common tension headache, which, look, it's annoying, and the absolute physiological beast that is the migraine.
That distinction is probably the most vital part of this entire discussion. And honestly, the first aha moment for me was just the definition of a migraine.
100%.
In pop culture, people use the word migraine to mean a really bad headache.
Right, it's a scale. If it's a 3 out of 10, it's a headache. If it's a 9 out of 10, it's a migraine.
Exactly. But clinically, that is completely wrong.
And the source makes this so clear. A migraine isn't just a worse headache. It's a genetic neurological condition. The headache is it's just the loudest part.
Precisely. It's a recurring primary disorder.
Yeah.
And it involves the gastrointestinal system, the neurologic system, the autonomic system. The head pain is just one symptom among a whole host of others.
A whole body event.
You have to think of it that way. It's a state the brain enters almost like a reboot sequence gone wrong, rather than just a sensation of pain in one spot.
Which explains so much. It explains why people feel so terrible even before the pain starts, or why they feel like they've been hit by a truck for a day after. It's systemic.
It is.
So let's set the stage. We're going to break this down into the biology, the why, then walk through the 4 distinct phases of an attack.
Which was news to me. 4 phases.
Right. And then finally, the minefield of treatment. And I use minefield very deliberately because, as we're going to learn, treating a headache too often can actually cause more headaches.
That paradox, the medication overuse headache,
Mm.
is one of the most critical takeaways we have today.
Yeah.
It's a trap that so many people fall into.
Okay, but before we get to the medicine cabinet, we have to look under the hood. The pathophysiology.
Yes.
Let's unpack that, because here's the thing that always trips me up when I think about brain science. The brain itself doesn't have pain receptors.
Correct. That's correct.
So you can be awake during brain surgery, someone can be poking your frontal lobe, and you won't feel a thing. So when I have a migraine and my head feels like it's being split open, what on earth is actually hurting?
That is the million-dollar question.
Oh.
It's deeply ironic, isn't it? The organ that processes all pain has no way to feel its own.
It's bizarre.
Since the brain parenchyma, the tissue itself, is insensitive, the pain signals have to be coming from the structures around it. And specifically, we're looking at the activation of the trigeminal sensory nerves.
The trigeminal nerve, I've heard of it, but what's its actual job?
Okay, so think of the trigeminal nerve as the primary surveillance system for your face and head.
Surveillance.
Yeah, it's detecting touch, temperature, and pain for your face, your jaw, and this is the key to the lining of your brain. In a migraine, this whole system gets hacked.
How?
It gets activated, triggered by something, and it causes the release of what the text calls vasoactive neuropeptides.
Okay, vasoactive neuropeptides. That sounds like a sci-fi weapon. Break that down.
Vasoactive means it affects blood vessels. Neuropeptides are just small protein-like molecules that neurons use to communicate.
Okay.
And the source lists specific culprits here: calcitonin gene-related peptide, or CGRP, neurokinin A, and substance P. When the trigeminal nerve dumps these chemicals, they cause the blood vessels in the dura.
The dura being the brain's covering.
Exactly, the tough covering of the brain. Those vessels dilate aggressively, they swell up.
And that widening, that swelling, is that the throbbing?
That's part of it, but it gets much more visceral. These chemicals also cause plasma extravasation.
Sounds incredibly gross. What is that?
It basically means fluid leaks out of the blood vessels and into the surrounding tissue. So picture this. Inside your skull, you have these swollen blood vessels that are literally leaking fluid, creating this soup of inflammation right next to the brain's sensitive coverings.
So it's almost like an internal allergic reaction.
That's a very good analogy.
Hmm.
The technical term is neurogenic inflammation.
Oh.
It's inflammation caused by the nervous system itself, not by a bacteria or an injury. It's a sterile inflammation. And your brain interprets that chemical bath as that pounding, severe rhythmic pain.
That paints a horrifying picture. It's not pressure, it's a chemical spill inside your own cranium.
Pretty much.
So why? Why does my trigeminal nerve suddenly decide to do this? To dump CGRP and this inflammation soup onto my brain? Is it just random bad luck?
Well, the source points to a really strong genetic component.
Right.
Twin studies suggest about a 50% heritability. But it's not simple, like having the gene for blue eyes. It's multifactorial and polygenic.
Meaning it's not one single migraine gene.
Exactly. It's a collection of them interacting with the environment.
So if your parents have it, you're essentially flipping a coin.
Roughly, yes. But here's a concept that really helps explain it. The genetic set point. Imagine everyone has a threshold for how much sensory input their brain can handle before just short circuits. For most people, that threshold is really high. They can stay up late, drink red wine, get stressed, stare at a screen, and they're fine.
Their buffer is huge.
Their buffer is huge. Exactly. But for migraineurs, that threshold is genetically set much, much lower. Their nervous system is just fundamentally hypersensitive.
So the triggers we always hear about.
They aren't the cause per se. They're just modulators that push you over that already low threshold. You're just working with the hair trigger system.
You know, that makes me feel a little better, honestly.
Well,
It's not that I'm weak or can't handle stress. It's that my genetic set point is just calibrated differently.
that's the right way to think about it.
Now, the text also mentions serotonin. I know serotonin is the happy chemical what antidepressants target, but what is it doing in a headache?
Serotonin, or 5-HT, it acts as a regulator here. There are specific populations of serotonin receptors that are involved in keeping those cranial blood vessels constricted and, normal. When serotonin levels drop or fluctuate, it essentially removes the brake. It allows that vasodilation, that swelling to occur. And this is really important because it foreshadows how the most effective drugs work.
Ah, the triptans.
Exactly. When we get to triptans later, you'll see they are agonists, meaning they mimic serotonin to tell those blood vessels to calm down and constrict.
Okay, so we have a genetic loaded gun, and the trigger pulls involve serotonin and this trigeminal nerve system spraying inflammatory chemicals. That's the machinery.
That's the machinery.
Now let's talk about what this actually looks like for the person suffering, because this is where just a headache myth completely falls apart. The source breaks a migraine attack down into 4 acts, and Act 1 starts way before the pain.
Yes, the premonitory phase. This is the warning shot. And the text notes this happens in anywhere from 12% to 79% of sufferers. It varies wildly.
Wow, that's a huge range.
It is. But it can start hours or even days before the headache actually hits.
Days. So you could be feeling this on Tuesday and not get the headache until Thursday.
Exactly. And the symptoms are bizarrely disconnected.
Yeah.
You might not even realize they're connected to the headache until you look back later.
The list is so strange. It includes things like yawning, stiffness in the neck, and food cravings. I mean, if I yawn 3 times in a row, should I panic?
It's very systemic. You see neurologic symptoms like difficulty concentrating or a sudden sensitivity to light photophobia.
Right.
But then you also get these constitutional symptoms: excessive thirst, frequent urination, which is called polyuria, and changes in bowel habits.
The psychological ones stood out to me. Anxiety, depression, irritability. That all makes sense. But then, surprisingly, euphoria.
Right.
You might feel weirdly great right before a migraine attacks you.
It happens. It really speaks to that chemical shift in the brain,
Yeah.
likely involving dopamine and serotonin. So if you have a sudden burst of energy, you clean the whole house, you feel invincible, and then you crave chocolate and start yawning.
That might not be a good day.
That might be the premonitory phase of a massive attack.
That is wild. It's like the calm before the storm, but the calm is hyper energetic. Okay, so that's Act 1. Act 2 is the famous one, the one that makes it into movies. But the source says only about 25% of people actually get it. The aura.
Right, the aura. This is a focal neurologic symptom that usually precedes the headache. It's basically the brain's electrical systems misfiring in a specific pattern.
How long does it last?
It evolves over 5 to 20 minutes, and it lasts less than an hour. If it lasts longer than that, we start worrying about other things.
And the most common form is visual, right?
Yes. The descriptions are incredibly specific. Scintillations, which are sparks or stars. Photopsia, which are unformed flashes of light. but the classic one is the fortification spectrum.
Which sounds like a military term.
It does. It refers to the aerial view of an old star fort. It's a zigzag line, often in a C shape, that shimmers and expands across your vision.
That sounds almost psychedelic.
It is, but you can also have negative features.
What's the difference?
So positive features are seeing things that aren't there, like the zigzags. Negative features are losing things that are there, like a scotoma, a blind spot, or heminopsia, where you literally lose half of your visual field.
Imagine driving down the highway and suddenly the left half of the world just vanishes.
It's terrifying. And it's not just limited to your eyes. The text mentions numbness and tingling paresthesias creeping up the arm and into the face.
Oh, wow.
And even speech issues, dysphagia. You might know what you want to say, but you can't get the words out, or you say the wrong words.
Which sounds, that sounds exactly like a stroke.
It mimics a stroke perfectly. And that's why the first time someone experiences an aura, especially if they don't get the headache right away, they often end up in the ER getting a CT scan.
So how do you tell the difference?
The key differentiator, according to the text, is the timing. A stroke is usually sudden, boom, loss of function, or a marches. It starts as a small spot and grows, or the tingling starts in the hand and moves to the face over minutes.
That march is the clue. But still, if it's your first one, you should get to a doctor.
Absolutely.
Now, usually within 60 minutes of the aura ending, we enter Act 3, the main event, the headache.
The part we all know. The source says this typically starts in the early morning. It peaks over minutes to hours, and it can last anywhere from 4 to 72 hours.
72 hours. 3 full days of pain.
That's the upper limit for a standard attack. If it goes longer, it's called status migrainosus, which is a medical emergency.
And the characteristics are very specific.
Very. It's usually unilateral, meaning it's on one side of the head, and it is throbbing or pulsatile. It beats with your heart because, remember, those blood vessels are dilated and inflamed.
So every heartbeat is just slamming against that sensitive nerve.
Exactly. And it brings friends. Nausea and vomiting are almost invariable, which is a strong term.
It means almost everyone gets them.
Yes. And then you have this sensory hyperacuity.
Right, where the patient is just stripped of their ability to filter sensory input.
Everything is turned up to 11. Photophobia, fear of light. Phonophobia, fear of sound. And osmophobia, fear of smells. Osmophobia is actually a very strong indicator of migraine specifically.
Really?
Yes. If the smell of perfume or cooking food makes you nauseous and elevates your head pain, it's very likely a migraine, not a tension headache.
So you're just hiding in a dark, quiet room, trying not to smell anything. And then finally, Act 4, resolution, the pain fades, but you're not back to normal.
No, not at all. This is the post-drome, or the migraine hangover. The text describes exhaustion, malaise, irritability. The storm has passed, but the wreckage is still there.
Your brain has run a marathon.
It has. A marathon of electrical misfiring and chemical imbalance. It needs time to recalibrate.
It's such a draining picture. And since we know we have this genetic predisposition, this loaded gun, we have to talk about what pulls the trigger. Section 3 of our deep dive, the minefield of triggers.
Yes.
There is a table in the source, table 54.1, that is just extensive. It feels like almost anything can cause a migraine.
It is extensive, and it's highly, highly individual. Identifying your specific triggers is half the battle of management.
Let's run through the big categories. First up, food. I see alcohol, obviously red wine is the famous one, but then caffeine. And this is just cruel. It lists both withdrawal and excess.
You can't win with caffeine.
You can't.
It's a double-edged sword because it's a potent vasoconstrictor.
Right.
It shrinks blood vessels. So if you drink a lot, your vessels are clamped down. If you stop suddenly, they dilate aggressively. Boom. Withdrawal headache.
But if you have a headache, sometimes it helps.
Right. A little bit of caffeine can help constrict them back to normal. It's a very delicate balance.
Okay, then we have the fun food list. Chocolate, fermented foods, pickles, and MSG, monosodium glutamate. Does MSG get a bad rap, or is it a real trigger?
The data is mixed, but for some people, it is absolutely a trigger. Same with nitrates, which are found in processed meats like hot dogs and bacon.
The hot dog headache.
Exactly. And we can't forget tyramine-containing foods, which usually means aged cheeses. Essentially, a fancy charcuterie board is a migraine grenade.
A charcuterie board is a migraine grenade. That is one of the most tragic sentences I've ever heard.
It's a sad truth for some.
Okay, then there's the environment. Glare, flickering lights, high altitude, and smells, perfume, and smoke.
Weather changes are a big one, too. Barometric pressure shifts can trigger that trigeminal system in sensitive people. You often hear patients say, "I can feel the rain coming." They're not lying. Their nerves are detecting the pressure drop.
But the category that really struck me, and I think this is the most insightful part, was behavioral physiologic. Sleep issues. Too little sleep triggers it, but so does too much sleep.
The Saturday morning headache. You sleep in to catch up, and you wake up in agony.
And related to that is stress. We all know stress is a trigger, but the text specifically mentions post-stress. This is the letdown headache. Can you explain that?
This is one of the cruelest aspects of the condition. You survive a high-stress week. Your cortisol levels are high, which might actually be protecting you.
Okay.
Then Friday night comes, you relax, cortisol drops. That protection is lifted. And the migraine hits you on Saturday morning.
So you finally get a break, and your brain just punishes you for it.
Exactly. It's all about that change in homeostasis. The migraine brain hates change. It craves routine. Same sleep, same food, same stress levels. Any rapid shift, even a shift towards relaxation, can pull the trigger.
The migraine brain hates change. That's a great way to put it. So you have to be boring to be pain-free.
To an extent.
Yes.
Regularity is the best defense.
Okay, let's say we failed at being boring. We ate the cheese, we stressed out, we slept in, the aura has started, the pain is coming. We need to talk about acute treatment.
Session 4.
The source has a golden rule here.
The golden rule is treat at the onset. Do not wait.
See, I struggle with this. I always think, oh, maybe it won't be that bad. I don't want to waste a pill.
And that is the mistake. Once that chemical cascade, the CGRP, the inflammation has fully set in, and that plasma extravasation has started.
The leak.
Yes, once the leak is started, it is exponentially harder to reverse. You're trying to put the toothpaste back in the tube. You have to stop the cascade before it floods.
Okay, treat early. So what are our weapons? The text breaks them down into tiers. Tier 1 is for mild to moderate attacks. This is your standard medicine cabinet stuff.
Analgesics and NSAIDs. So aspirin, diclofenac, ibuprofen, naproxen, they work by inhibiting prostaglandin synthesis, which helps stop one pathway of inflammation.
And the text specifically highlights one combination.
Yes, the combination of acetaminophen plus aspirin plus caffeine.
That's basically the formula for Excedrin migraine, right?
Correct. The caffeine helps the absorption, and it provides some vasoconstriction. It's highly effective for many people if you take it early enough.
But for moderate to severe attacks or when NSAIDs fail, we move to Tier 2, the specifics. Drugs designed for migraines. This is where we get into the triptans and the ergots. Let's start with ergots, they sound.
They are older drugs, ergot alkaloids. They're actually derived from a fungus that grows on rye. Back in the Middle Ages, people would eat infected rye and get St. Anthony's fire, which was gangrene from massive vasoconstriction.
Okay, that took a dark turn.
It did. But we harness that power. Ergots constrict blood vessels very powerfully. You can take them orally, rectally, or DHE, which is a nasal spray or injection.
But they come with warnings.
Big ones. Because they're so potent at squeezing blood vessels, ergotism is the risk-severe peripheral ischemia. Cold, numb limbs. It's rare with modern dosing, but it's why doctors are careful.
Right, which brings us to the modern standard, the triptans. Sumatriptan, zolmitriptan, rizatriptan. These were a revolution in the 90s, right?
Absolute game changers. Before triptans, we didn't have much. Triptans are selective serotonin agonists. They target the specific serotonin receptors on those cranial blood vessels and nerve endings.
So they fit in like a key into a lock.
A perfect analogy. They fit into the receptor and tell the artery to constrict and tell the nerve to stop releasing CGRP. They stop the leak.
But they have their own weird side effects.
Yes, the triptan sensations. Patients report chest tightness, pressure, or a feeling of heaviness in the neck and throat.
Which sounds like a heart attack.
It feels like one, which is terrifying. The text emphasizes that this is rarely cardiac in origin. It's likely constriction of the esophagus or chest wall muscles. But because they do constrict vessels, they are generally contraindicated if you do have heart disease or uncontrolled hypertension.
You don't want to constrict the coronary arteries.
Exactly.
Okay, now we have to talk about the vomit comment. The source makes a huge point about antiemetics drugs for nausea, but it's not just to stop you from throwing up, is it?
No, and this is a critical point that is so often missed. During a migraine, patients suffer from something called gastroparesis.
What's that?
The stomach essentially becomes paralyzed. It stops churning. It stops passing food to the intestines.
So if you pop an ibuprofen or a triptan pill,
It just sits there. It sits in a pool of acid in your unmoving stomach. It doesn't get absorbed into the blood. So you're waiting for relief that physically cannot arrive.
that explains why so many people say pills don't work for them. Their stomach is offline.
Exactly. That's why the text suggests pre-treating with an antiemetic like metoclopramide. It stops the nausea, yes, but it's also a prokinetic. It kickstarts the stomach. It reverses the gastroparesis so the pain medication can actually get into your bloodstream.
Or you bypass the stomach entirely.
Right, with a nasal spray or an injection.
That is a life hack level tip. Treat the stomach to treat the head. We arrive at section 5, and this is the part that genuinely scared me. The paradox of treatment. Medication overuse headache.
It used to be called rebound headache.
Yeah.
This is the most dangerous trap for migraine sufferers. If you use acute medications too frequently, you actually alter the brain's pain regulation systems.
You make it more sensitive.
You make the receptors more sensitive. You're trying to stop the pain, but by taking the pill, you're actually feeding the cycle.
So you're creating a dependency, not on a high, but on the relief, and the withdrawal is more headache.
Yes. As soon as the drug wears off, the brain screams for more, so you take another, and the cycle tightens.
So what's the limit? How much is too much? The text is very specific here.
It is. The general red line is that acute therapy should be used fewer than 10 days per month, total.
10 days, that's it.
And specifically, if you are using combination analgesics like Excedrin or ergots or triptans, you should limit them to 2 or 3 days per week, maximum.
And NSAIDs.
They have a slightly higher allowance, around 15 days per month, but even those can contribute.
So if you're the person waking up with a headache every day and popping an Excedrin with your morning coffee just to get to work?
You are almost certainly causing the daily headache.
Wow.
And the only way out is to stop the medication, which means you have to endure the withdrawal headache, which is brutal, for days or weeks until the brain resets. It's a very difficult detoxification process.
That sounds absolutely miserable. So if you're hitting that limit, if you're having 3 or 4 attacks a week, you can't just keep taking triptans. You have to play defense.
Exactly.
This leads us into section 6, prophylaxis or prevention.
Right. We consider prevention when attacks are frequent, when they're disabling, or when the acute meds aren't working. The goal here isn't to stop the pain during an attack, but to raise that genetic set point so the attack never even happens.
The drug list for prevention is fascinating because none of them were originally designed for headaches. We're borrowing them from other diseases.
It's the big 4 FDA-approved options. We have 2 beta blockers, which are blood pressure meds, and 2 anticonvulsants, which are seizure meds.
Okay, let's talk about the seizure meds first. Topiramate. I have heard friends call this Dopamax.
That is the colloquial nickname, yes, and for good reason. Topiramate is effective, but the side effect profile is significant. It can cause cognitive slowing,
Meaning?
memory difficulty, language problems. Patients literally have trouble finding words in a meeting. It can make you feel dopey.
That is a massive trade-off. I don't have a headache, but I can't remember the word for stapler.
Exactly. It also causes paresthesias, tingling in the fingers and toes. And interestingly, it causes weight loss.
Which is the opposite of the other anticonvulsant, Divalproex or Valproate.
Right. Valpro can cause weight gain, tremor, and even hair loss.
So you're sitting with your doctor basically balancing these side effects against the pain. Do I want to be thin and forgetful or heavier with a tremor? It's not an easy choice.
It's a very personal decision.
And what about the beta blockers, like propranolol?
They're generally better tolerated. They work by dampening the sympathetic nervous system, but they can cause fatigue, depression, and exercise intolerance because they prevent your heart rate from going up. And you have to be careful if you have asthma.
Are there any natural options mentioned for the listener who is maybe terrified of Dopamax?
Yes, thankfully. The text mentions magnesium, which can be particularly helpful for migraines with aura or menstrual migraines.
Okay.
Riboflavin, which is vitamin B2, is another one, though the text notes it takes about 3 months to show benefit. You have to be patient. And then there are herbs like feverfew and petacites, which is butterbur.
But there's a big flashing red warning on butterbur.
A huge warning. The plant itself contains what are called pyrrolizidine alkaloids, which are carcinogenic and toxic to the liver.
So you can't just brew butterbur tea?
Absolutely not. You must use a specialized commercial preparation that has removed these toxins. Please, do not DIY your butterbur.
Good advice. Do not brew carcinogenic tea. Yeah. Okay, we have covered the absolute monster that is migraine, but before we wrap up, we have to address the other elephant in the room. The headache that isn't a migraine. Section 7. The tension-type headache.
Common cousin. This is the most common type of primary headache in the population, but the presentation is completely different.
So how do we tell them apart? If my head hurts, how do I know which one it is?
Location and quality of the pain. A migraine is usually unilateral, one side, and throbbing. A tension headache is bilateral, both sides, and it's non-pulsatile. It doesn't throb.
It's a steady ache.
A steady pressing ache. Patients often describe it as band-like, like a tight hat or a vice gripping the head.
And the accompaniments, the nausea, the light sensitivity.
Usually absent, no aura, no vomiting. You might have mild light sensitivity or sound sensitivity, but usually not both. It's a much cleaner headache,
Yeah.
purely in terms of symptoms, just pain, without all the neurological fireworks.
The pathophysiology here seems less genetic and more mechanical.
That's a good way to put it.
Mm.
It involves myofascial factors, tenderness in the muscles of the head and neck, peripheral sensitization of pain receptors in those muscles, and of course stress, mental stress, or non-physiologic motor stress.
Which is a fancy way of saying tech-neck.
Exactly. Sitting at a computer with bad posture, hunching your shoulders, that tension translates directly into the scalp muscles.
So treatment seems simpler here.
It is. Non-drug therapies like stress management, relaxation, biofeedback, and just fixing your posture are key. For drugs, simple analgesics and NSAIDs are the mainstay.
But here is a mythbuster from the source that I need you to clarify. Muscle relaxants. I feel like people always ask for these for tension headaches because, well, it's in the name, tension.
And the text is explicit on this. There is no evidence to support the efficacy of muscle relaxants for tension-type headaches.
None.
None. It's a common misconception. Doctors might prescribe them for the sedative effect to help you sleep, but they don't fix the headache mechanism. You are better off with ibuprofen and a stress reduction technique.
Wow. That changes a lot of prescriptions I've seen. Okay, let's bring this all home. We have covered a massive amount of ground today.
We really have. We've gone from thinking of a headache as just a simple pain to understanding it as a neurovascular event.
Right.
We talked about the genetic set point, that 50% heritability. We walked through the 4 phases, the weird premonitory warning signs, the stroke-mimicking aura, the throbbing unilateral pain, and then the hangover.
We navigated the trigger minefield, the cheese, the letdown after stress, the sleep issues, and we hammered home the danger of medication overuse. You can't just pop pills like candy, or you will end up in a cycle of constant pain.
And that really brings us to the so what of this whole deep dive.
Mm-hmm.
The goal of treatment, as the text states, isn't just zero pain. It is normal functioning.
Right.
It's the ability to resume your daily life without the constant fear of the next attack. It's about management, not necessarily a total cure.
That's a really healthy way to frame it. Now, I want to leave the listeners with a final thought. You mentioned earlier that migraines are genetic, and they involve this incredibly specific, complex sequence of events, the aura, the sensory heightening. It all feels so organized.
And it does. It's not chaotic. It's a specific program the brain runs.
So here's my provocative thought. If this affects so many people and has survived in our gene pool for so long, is it possible that this hypersensitive sensory system actually served an evolutionary purpose?
The sentinel theory. It's fascinating.
Tell me more.
Well, think about an ancient tribe. You have a group of people. Most of them have high thresholds. They sleep through the storm. They eat the slightly off meat. But then you have one person, the migraineur, who is hypersensitive.
Okay.
They smell the smoke before anyone else. They feel the barometric pressure drop before the storm hits. They are the first to react to a threat.
So the migraineur was the canary in the coal mine.
Exactly. Their hypersensitivity was a survival advantage for the group, protecting the tribe, even if the cost to the individual was that sometimes their brain short-circuited and incapacitated them.
That is a beautiful way to look at it. You aren't broken. You are just the over-vigilant sentinel for a tribe that doesn't need one anymore.
It's definitely something to chew on while you're resting in a dark room with an ice pack.
Absolutely. Well, to all our listeners, we hope this helps you decode what's happening inside your head. Whether you are the sufferer or you're the support system, understanding the biology is the first step to managing the storm. Thanks for diving in with us.
Stay curious and take care of your brain.
See you next time.